It is my it's my real privilege to be able to introduce today's speaker, Dr. Margaret Herridge. Dr. Herridge is a professor in the Department of Medicine, a senior scientist in the Toronto General Hospital Research Institute and University of Toronto Interdepartment Division of Critical Care Medicine. She's director of the CHR-funded National Recover ICU Care Continuum Program, the Grace Recover Program for Chronic Critical Illness. She's co-lead of CANCOV, which she is going to be presenting to us today, and is truly a recognized international content expert on patient and caregiver outcomes after critical illness. Marg Herridge has really birthed this whole field of research. She has received, I have her bio in front of me. She's received multiple national and international research distinctions and awards. I'm just going to highlight a few of them. She received a Lifetime Achievement Award in Critical Care from the American Thoracic Society. She is a fellow of the Canadian Academy of Health Sciences. She's a recipient of the CHR Canadian Critical Care Society Distinguished Lecturer Award in Critical Care Sciences, and she's a current Tier 1 Canada Research Shareholder in Critical Illness and Outcomes and the Recovery Continuum. Marg, it's a real pleasure to have you today. Thank you so much for presenting to us, and the floor is yours.
Well, thanks so much, Jane, and it's really an honor to speak to everyone today and to share some, I think, maybe sobering information in terms of outcomes after COVID. But I hope great information to be able to share with everyone and to really learn from. So I'm going to start today with a little bit of background and just start off also by saying that I don't have any conflicts of interest to declare. I don't have any relationship with industry. And I do want to take one moment to say that this work, led by Angela Chung and myself, we really dedicate to all the patients, the caregivers. I like to indicate children because we dealt with a lot of children in this, which was its own discussion, and healthcare workers who suffered during COVID and continue to experience the sequelae from this pandemic. So very briefly, I wanted to outline the landscape in terms of what we already know about ARDS, sepsis, SARS, and patients who required prolonged mechanical ventilation, to review the post-COVID-19 condition, and to review the literature that already exists that's germane to what I'm going to talk about today, to just give you a sense of the knowledge gaps for COVID critical illness, which really does represent an important knowledge gap. There are not really any granular international cohorts that highlight really and focus on really our sickest patients. And then show you the data from our CANCOV study. I'm going to present the ICU arm that I lead. Angela's been leading the ambulatory and hospitalized non-ICU arms, and explain a little bit about the implications and the relevance of these data. I want to start off by just one slide highlighting that COVID critical illness was really all about severe lung injury. And severe lung injury that met in many situations the formal criteria for the acute respiratory distress syndrome, initially characterized in 1967, so a long time ago, and typically characterized also by bilateral airspace changes you see on the upper right, and very significant hypoxemic respiratory failure related to low pressure pulmonary edema. I want to go back over 20 years and at the risk of aging myself, and just talk a little bit about our original ARDS cohort, because it's relevant to what I'm going to show you today. A lot of what I'm going to show you was predictable in terms of COVID critical illness outcomes. And our cohort over 20 years ago, published in 2003 in the New England Journal, highlights a few things. The first is that, and this is a cohort of patients who had 4-quadrant airspace changes. They were our sickest ARDS patients in the intensive care unit in the late 90s and early 2000s. These tended to be younger people with a median age of 45, and they typically were there because of pneumonia or other forms of sepsis. They were mechanically ventilated for about 3 weeks and in the unit for 3.5. And I just want to highlight that, I don't know why this keeps advancing, why that the ICU mortality was 40% in this group. It was very high, and there were extraordinary challenges with ICU acquired weakness with very protracted rehab times. And I'll show that in a minute. Patients lost about 20% of their lean muscle mass. And even at a year, and you can see here, I'm just showing a few brief data, that the distance walked in 6 minutes in this group of young people was 66% of predicted. It's quite staggering, and there were very important decrements in physical domains of quality of life. And this was really exposed, or this is really related, associated in multivariable analysis with sex, women more vulnerable, exposure to systemic corticosteroids, the duration of organ dysfunction, and the rate of resolution of lung injury, and burden of comorbid illness. So some of these seem to recur, and later on, just to highlight that. So ICU acquired weakness is its own lecture, but just to highlight that this really encompasses myosin depletion myopathy and an axonopathy, where there is actually axonal injury, and it's ischemic injury, and these represent important end organ injuries in critical illness. And not only the muscles of the axial skeleton here in this Zudin-Puthachiri JAMA paper, but in the diaphragm, and other important work that's been contributed by Mike Sklar, Ewan Gallagher as a leader in this area. And here's some 2-year outcomes data contributed by Eddie Fanwood. He was doing his PhD with Dale Needham. So a lot of data, a very robust finding, and a very important morbidity after critical illness. And ARDS in particular. Another important morbidity, neuropsychological dysfunction, initially put on the radar by an article in the Blue Journal by Mona Hopkins. This was 1999, around the same time that we were doing our ARDS cohort. And she noted that patients had important neurocognitive dysfunction, problems with memory loss, processing speed, executive dysfunction, which remains one of the major barriers to return to work. Patients had age-inappropriate cortical loss, you can see here in the lower left-hand corner. And more recent data from the brain ICU cohort led by Pratik Pandropandi and Wes Ely show important sequelae related primarily to the duration of delirium and cognitive dysfunction on the order of mild Alzheimer type dementia and moderate TBI. These are people who do not have stroke or an overt brain injury, but important microglial activation and neuronal apoptosis. The lungs in our cohort and other cohorts with historic ARDS tended to recover to normal or near normal lung function, and tended not to be an important contributor to functional disability. Our group and other groups on the right-hand side is Dale Needham's group from Hopkins many years after we published ours, showed a persistent reduction in physical function at 5 years. So recall that our cohort had a median age of 45. These are young patients who acquire a long-term disability. And it's not just a disability, it has health system implications, where we see here in our 5-year cohort that the costs reported are higher than those incurred by healthy workers. The costs are much closer to the low end of costs of patients with chronic disease states. So we're really talking about a group of patients who incur new chronic illness at a time when they are working and have young children, and do not return to their functional status on average, nor do they return to their baseline healthcare utilization. Now, apart from ARDS, there's a robust literature on sepsis. And remember, COVID was a novel viral sepsis. It's a virus. We have seen viruses before, but this was novel and particularly pernicious. But when we look at the sepsis literature, we see similar trends. And this is an important landmark paper from Jack Awash and now at Hopkins. And Jack showed that with each episode of sepsis, patients have a decrement in their mean number of activities of daily living and instrumental activities of daily living. So with each episode, people sustain additional disability. As well, in their paper, they showed what Mona Hopkins showed in 1999. This is now 2010, that there were important decrements in cognition, not that can be moderate to severe and also follow episodes of sepsis. So we're seeing a few themes here emerge, and prolonged mechanical ventilation. So the COVID patients in the ICU tended to stay a long time. And the historic literature on prolonged mechanical ventilation was a time point of 3 weeks. And this is associated with very high hospital mortality, acute hospital mortality of 20 to 49%, and at 1 year, almost 70%. And you see a lot of the sequelae of chronic critical illness. People are vent dependent because of diaphragmatic dysfunction and muscle weakness, brain dysfunction. You can see all the things that I've already mentioned, and a few others that relate to pressure injuries. Patients have a lot of symptom distress and various endocrinopathies. Now, our own Recover group tried to modify the bound of time within which one categorizes ICU patients as having chronic critical illness. And we looked at patients after 1 week of mechanical ventilation, regardless of admitting diagnosis, and really found a few things that at 1 week, you really could determine, well, at 1 week of mechanical ventilation, it was an important marker of 2 or more weeks of mechanical ventilation. And at 2 weeks, we really could determine patient trajectories out to 1 year in terms of disability and mortality based on age and ICU length of stay. And showing that you don't need to stay that long in the ICU to have a lot of these various sequelae. Again, another lecture. And we had a parallel arm in this study led by Jill Cameron, and Jill and I were the co-PIs of this first phase of Recover. And just to highlight a few things, at 1 year, our family caregivers in this cohort, 27% of them at a year still were suffering from severe depressive symptoms. Some of these patients reported suicidality and problems with substance misuse. They got very, very sick, and very important to highlight that because I'll refer to that a little bit later. So in terms of the ARDS, sepsis, and prolonged mechanical ventilation literature, it's very clear that prior to COVID, we knew that complex critically ill patients had cognitive dysfunction, had important mood disorders. These were brought together in a few syndromic constructs led by Dale Needham. The so-called post-intensive care syndrome described in 2012 after a lot of this literature had been published. This has been extended recently and highlighted that it needs to include frailty and other diverse multimorbidities. And the families get sick too, as evidenced by the post-intensive care syndrome family. Finally, I just want to make a couple of additional comments. These patients who are complex in the ICU become complex in the community and in the hospital. And they really get trapped in care transitions because they have a problem getting better, is the bottom line. They're struggling because they've lost a lot of their organ resilience, and they're really struggling to finally transition successfully to the community. And also to get back to work. So here's an important paper showing that the greater the burden of the Charlson Comorbidity Index, i.e. the greater your burden of chronic disease, the less likely you are to return to work, which is intuitive, but very germane to survivors of critical illness who come to the ICU increasingly with advanced stage and a higher burden of comorbid illness. And this is precisely a vulnerable group who incur even further organ injury and have a very difficult time not only transitioning to the community, but transitioning back to work. So I want to talk next about SARS. These are not pictures from COVID for those who weren't working in 2003. In 2003, these are pictures from SARS. And some of our important leaders at that time, Don Lowe, who tragically we have lost, but Alison McGeer, who was recently honored with Order of Canada recognition. Congratulations to Alison. And to show folks that this, we went through this in Toronto already and maybe didn't learn all the lessons that we hoped we could. One of my, our research coordinator who did the ARDS study with me and following the patients in clinic with me, Kathy Tansey, subsequently did her PhD. And she led the follow-up with me and others on the largest international cohort of SARS survivors. I just want to highlight a few things because, again, the themes are robust. Now, this particular cohort of patients had very few ICU patients in it. But despite that, we still could see that some patients had important pulmonary restrictive physiology. Still, people had important functional disability measured as the distance walked in 6 minutes. Decrements in physical health and mental health. We studied the caregivers too, who also had very important decrements in mental health. Jill Cameron also collaborated on that with us. The most prevalent consultation was psychiatry. And still, despite the fact that most of these patients were not critically ill, a lot of people did not return to work. And what did we learn in clinic? We learned a lot of the same things that we heard in our CANCOV ICU follow-up clinic. Patients felt stigmatized. They experienced the deaths of close family members and coworkers. They were traumatized by their inability to be present at the time of death or attend funerals because of quarantine. They noted enormous emotional strain of quarantine and profound challenges related to isolation. They were very fearful. They sustained a lot of psychological trauma. And when healthcare workers were in the room, their impact was enormous in terms of combating a lot of the fear, anxiety, isolation. So we all know that COVID began as sort of a very, very large descriptive study. And it quickly became evident that COVID was a generalized severe endotheliopathy that resulted in multi-system sequelae. And papers really began to quickly emerge, showing challenges with brain injury, cardiac dysfunction. In the unit, we were clearly hearing about this from colleagues as the pandemic moved from east to west, and renal dysfunction as well. We were seeing that this was truly a ferocious multi-system organ disease. Now, in terms of the ICU world, it was kind of interesting because we were seeing that patients, oops, I'm so sorry, I just lost my presentation. What just happened there? That the patients we were seeing were experiencing a change in the technology that was going on now in critical care internationally. And this was really two things. One was the uptake of high-flow nasal cannula and really our ability to look for ways to temporize critically ill ARDS patients through an increase in positive pressure in the upper airway, decrease in dead space, and we could use up to a FiO2 of 1 with 60 liters of flow. And in some high-impact papers, it seemed as though this could in fact improve 90-day mortality. Similarly, there had been a real uptake in extracorporeal membrane oxygenation. And for our current study, we were already in the ICU using the Eolia criteria from Alain Combs' New England Journal study, and where patients with severe ARDS were being placed on ECMO, and some signal that this may in fact improve survival and may have an important role in lung protective strategies. So there was a real intersection of technology. Similarly, there was revisitation of ARDS definitions, both by Michael Mathey, a colleague of ours in the United States, and through the European Society of Intensive Care Medicine. And one of the robust themes here in these two ARDS guidelines, which many of us in Toronto had the privilege of participating in, there was a real interest in what happened in including patients on high flow nasal oxygenation in these definitions, which historically were limited to patients who were invasively mechanically ventilated. And also an overwhelming desire to generalize these definitions to allow them to be more accessible in developing countries. The other thing that began to develop was the real uptake of platform trials and looking at multiple research questions simultaneously. And I would say the readoption of a short-term outcome, 28-day mortality outcome, as the outcome of choice for platform studies. And one of the most celebrated platform study outcomes was the dexamethasone in hospitalized patients with COVID-19 and how this improved outcome. So there have been different publications after COVID highlighting long COVID. And for those of you maybe less familiar with this, there were a couple of important documents. There's the WHO document and the NASM document from the National Academies of Science, Engineering, and Medicine. And basically, this involves the persistence of COVID-19 symptoms longer than 12 weeks. The challenge with these definitions is they've largely relied on symptom persistence. And this is another thing that our study was really trying to address. So very quickly, in the next couple of minutes, I just want to highlight a few things and go quickly through time from early post-COVID studies. And this can't be comprehensive, the literature is immense. But to just show you here in the comeback study published in JAMA at 4-month outcomes, you could already see a signal here in terms of some pulmonary dysfunction, restrictive physiology, and cognitive impairment here captured by the MoCA. At 6-month outcomes, and this is the original cohort from Wuhan led by Bin Cao, the intensivist there, also seeing the decrements in quality of life here measured by EQ5D with mobility, personal care, really challenges with usual activities, and decrease in distance walked in 6 minutes. And some pulmonary sequelae as well. And persistence of radiographic findings even at 6 months with ground glass opacifications. The FOSSA COVID UK cohort at their 5 to 7 month follow-up really tried to begin to understand if there were phenotypes and if there were, and within these phenotypic groups, and you can see them here, intersection of the cognitive impairment and other symptoms and physical performance impairment on the y-axis, to try to characterize these individual groups based on comorbidities and obesity. And they identified 4 different phenotypic clusters. Further at 1 year, we began to see studies, again, this has been Cao's Wuhan cohort, where you could see that some people were really having a problem returning to work. And this cohort was also relatively young. And when people didn't return to work, they indicated that they didn't return because of decreased physical function. And there's a persistence of symptoms even to 2 years. Here's another 2-year study, not from the Wuhan cohort, but another with important chest tightness, anxiety, and fatigue still at 2 years, but with an important signal now emerging in the beyond 1 year studies, now increasingly limited, that the most symptomatic patients were the ICU patients. And here at 3-year follow-up, this is a more recent paper showing that patients with any degree of neurological impairment had a decrease in survival and much more complicated outcomes in terms of needing rehab or discharge to skilled nursing facilities. And again, at 3 years, seeing that patients were still very symptomatic. This is the Wuhan cohort again, and that if you were vented, you had many more symptoms at 3 years. And really, ICU admission was associated with respiratory symptoms, much less so the hospitalized non-ICU people and the ambulatory people. And finally, before I get to our data, you can see the 3-year here. This is a large VA cohort. And again, at 3 years, showing actually continued accrual of mortality in the hospitalized COVID-19 patients at 3 years. And you can see here at 3 years, this is the yellow bar, that people continue to have multi-system issues. The ECMO group does not have a lot of granular data beyond 1 year. And here's a nice paper from the Blue Journal showing some recovery of lung function, but persistent mood disorders, a lower proportion returning to work, and a significant proportion having persistent sexual dysfunction. I want to just take one slide to talk about the impact on family caregivers. To the right, this is a schematic. This is from a review paper that Elie Azoulay and I wrote for the New England Journal on outcomes a couple of years ago now. And we wrote this during COVID, and I think we really wanted to express the multi-generational trauma that's going on at the bedside and how this plays out afterwards. The episode of critical illness in COVID, but also historically among adult patients, but pediatric ICU parents, neonatal ICU parents. This is a very, very robust literature. From stress, have an increase in mortality, severe mood disorders, panic disorder, may have problems with complicated grief, suicidal ideation, and suicide. I'm sorry to say we had a suicide completed in the caregiver arm of our CANCOV cohort in a patient who had no prior history of mental health problems with substance misuse disorder, financial stress, and problems getting back to work. So not to underestimate the impact on the patient, the family, healthcare workers, everybody. And finally, the de-adoption of best practice, which was a very regrettable theme during COVID, that the A to F bundle, which is really one of the major tenets of best practice in ICU, was deprioritized, is a word I would use. And I just want to highlight that the families, because they weren't at the bedside, it really exacerbated the trauma that I just outlined to you. And it was really very difficult to engage in early mobility and exercise, in particular for patients who were vented or on ECLS. So in this landscape, I highlight now the knowledge gaps that we tried to address. There were really no granular cohorts of severely critically ill patients out to 3 years in the international literature. We really wanted to characterize the trajectories from ICU to 3 years and a priori stratified by the highest level of life-sustaining treatment. We wanted to add to the ECMO literature in terms of detailed outcomes beyond 1 year, and to understand if there were also symptom cluster phenotypes within our own data set, as I showed you from the FOS-COVID, to 3 years, and whether they were associated with measured multidimensional outcomes to move beyond the post-COVID condition symptom-based definitions, and to really validate that the symptoms reflected measured outcomes. This was a huge study, and there are many, many people to thank. I want to acknowledge my co-PI, Angela Chung. Always a pleasure to work with Angela, and our division of the cohorts. I want to also really give a shout out to Dr. Priscilla Robles. For the ICU cohort, Priscilla was our project manager. Priscilla is a physiotherapy scientist and a PhD scientist, and we could not have done this without her. And I thank all the members across Canada who helped with this. It was a Herculean effort, and we continue. This was designed to really describe short and longer term outcomes. It was designed as a 1-year study, and we've extended it to 5 years. Our overall hypothesis was really trying to understand clinical risk factors associated with sort of a myriad of short and long-term outcomes that I'll highlight in a moment. And our specific a priori hypotheses, now turning to the ICU cohort, were the following: that patient trajectories and outcomes may be stratified by highest level of life-sustaining treatment, i.e. these people are on very distinct strata right from the ICU, that there are that we de-adopted ICU best practice. Well, we were living that and just wanted to verify that. That 28-day mortality is not reflective of ICU or 1-year mortality or beyond, or morbidity outcomes. And that post-COVID critical illness symptoms, are these just, post-intensive care unit syndromic symptoms, or is there something unique about this? And to understand the pivotal role that ICU follow-up clinics play in a post-pandemic follow-up. A primary outcome was a functional independence measure that we used in our Recover program that's been going since 2006. It has a motor domain and a cognitive domain. And the reason why we chose this was we knew that the PFT labs would open and close, and we wanted to use a metric that had already been validated to 6-minute walk distance and the physical component score of the SF-36. And I just show you a correlation table here from our Recover study. So this is why we chose that. Our study sample, we recruited from 12 academic and community ICUs across 4 provinces. We started in July of 2020. We recruited to March of 2022. This was an ambidirectional cohort, which I'm happy to talk a little bit more about. We had to recruit during the first wave retrospectively because we were waiting for REB approval, and it was our 3-year follow-up was completed on April 30th of 2025. These data are currently under peer review. It was easy to get in the study. You just had to be over 16 and have PCR positive for COVID-19. And basically, we wanted to be very inclusive and only excluded people who we really felt were moribund or really unable to comply with follow-up. And we initially had geographic restrictions, but those were amended as we began to follow people through Zoom and on by the telephone. So our cohort is 388 patients across Canada and 78 caregivers. The caregivers didn't want to be part of this study because they were honestly pretty traumatized, but a certain number agreed, and that's data that maybe I'll show another day, but I just want to focus on this now. All of the multidimensional outcomes are at the top here. So I would say this is the biggest cohort study I've ever done. The data set's massive, and we really tried to hit as many domains of psychological and physical health as we could, including things like resilience and stigma and nutritional status. I'm only going to show you a little bit of this. The cohort, many people have reached 5 years now. The cohort is moving now, it's about 3.5 years, 3 to 3.5 years. And we hope to finish 5-year follow-up. Our cohort follow-up has really been excellent, and this is a testament to our fantastic group and collaborators across Canada. The cohort follow-up has been over 80%, and the completion of our primary outcome has similarly been over 80% to 3 years. I would say that once 2 sites completed the study at 1 year, which was the original contract, and didn't feel they had resources to continue. Another site extended to 2 years and then stopped also for resources. but we have 9 sites that extended to 3 years. So this group had a mean age of 54. Most were men, and ICUs are filled with more men than women. We have perhaps the most ethnically diverse cohort in the world because a lot of these patients were recruited from metropolitan centers in Canada. I want to highlight that our cohort was pretty socially stable. And also that 2/3 of people were working part or full time. They had the metabolic syndrome that all of you folks are now familiar with. We had a high prevalence of pre-existing mental health conditions. I highlight, though, that we asked people for anything ranging from informal counseling to mental health admission. So there's a broad spectrum there. We had some people who were obese, morbidly obese, and most people came from home. So I emphasize that most people came from home and they were working. Now I'm going to begin to show you the data stratified by highest level of ICU treatment. And this was done a priori before we understood the data set. The ECMO patients, the vented patients, the high flow nasal oxygenation patients, and a group that was aimed at non-invasive ventilation and oxygen, but actually it only included people with oxygen. We didn't have any NIV people in this group. You will see that everything is significant, and we go from youngest age group, which was deliberate. We put people on ECMO who were the youngest and least comorbid, up to people who are on oxygen. All of them had important lung injury severity scores. The ECMO and mechanically ventilated patients had more organ dysfunction, less chronic disease by design, high levels of renal replacement therapy, 10 to 13 days of time to renal replacement therapy, high prevalence of tracheostomy and times to tracheostomy. I want to show you here, unfortunately, the de-adoption of best practice. And again, the same categories: ECMO, mechanical ventilation, high flow, and oxygen. You'll see that the patients had a lot of exposure. So here are pressor support. ECMO patients had the most pressors. But you'll see here a lot of continuous sedation, narcotic, the ECMO group typically having the most, and there's sort of a dose-response relationship, a lot of paralytic exposure. Unfortunately, a lot of deep coma exposure, which we know can be injurious to the brain, cumulative days on antibiotics as well, and lots of steroid use in both the vented and the ECMO patients. And obviously, the ECMO patients were more frequently anticoagulated. The point I want to make is in the ICU, the ECMO patients' median length of stay was 34 days, 17 for the vented people. And you can see much less for the high flow and the NIV people. And the dash here is 0%. Now, when we did an alluvial plot looking at mortality at 28 days, I want to just show you the following. These are patients who were discharged. The oxygen people are in gray, high flow in the light blue, vented dark blue, and ECMO red. And these are the patients who died. And you'll see in the first 28 days, a lot of the oxygen and the high flow people were discharged. But at 28 days, a lot of the ECMO and the vented people were still there. And at 28 days, the ECMO mortality was 28%. So if you stopped a study at 28 days, you would absolutely conclude that there was a survival benefit here. Unfortunately, when we looked at patients for an additional 120 days, that's in the ICU, the cumulative mortality was 50% in the ECMO patients and 25% in the mechanically ventilated patients. And what we also saw was there was high ongoing mortality in the ECMO patients despite being younger and less comorbid, which I just showed you. And when we looked at mortality over time, you can see that the cumulative mortality increased in the ECLS and the vented patients from 28 days to ICU mortality. But there was continued mortality during the first year of follow-up and even during the second year of follow-up, where we're really ending up here with a cumulative mortality in the ECMO group of 63% and 33% in the vented group. So the patients are on very different trajectories in a whole host of ways. And when we looked at symptoms, now this is across the entire cohort. And you can see 3, 6, 12, 24, 36 months. And at 36 months, you see that muscle weakness that was prevalent was a lot better. Hair loss, alopecia, a lot better. But what's still very prevalent? Well, just as a summary statement, 75% of our patients had at least one symptom at 3 years. Over 40% continue to have symptoms of shortness of breath, fatigue, and cognitive symptoms. And these were, in fact, associated with measured outcomes of pulmonary function, functional status, and cognition. Mood symptoms were associated with our measured mood outcomes. And the muscle weakness, weight loss, and hair loss did improve over time. We looked to see if there were symptom clusters. And in fact, there were two symptom clusters that became evident through latent class analysis. And I would want to acknowledge George Tomlinson, Ella Husti, and Shishwan Lee, who helped us with all the statistics here. And George worked on this with me. And what we did is we took the top 15 symptoms, really a priori, and then we did a latent class analysis. And there were two very, very distinct clusters. One cluster with high severity symptoms, one cluster with low severity symptoms. And then without looking at the data set in advance, we really did hypothesize quite obviously that the higher symptom cluster would be our higher severity symptom patients. And in fact, that was the truth, that the higher symptom cluster were the ECMO and the vented people, and the lower severity were the high flow and oxygen patients. We also could see that the symptom clusters were significantly associated with the FIM. So the higher symptom cluster, or the higher proportion of patients in the higher symptom cluster, had a lower FIM, and that actually there was a significant difference in the FIM between each of these clusters during the 3 years, 3-year follow-up, although the difference decreased over time. We could see, and here are some other figures to show you that the motor FIM here and the 36 months improved to 3 years. The ECMO is red, the vented is the dark blue, the high flow is the light blue. Everyone had important physical improvement. Younger patients had important physical improvement, but wasn't back to normal on average. Pulmonary function was the worst in the ECMO group at 3 years, and they had the highest oxygen use. You can see the TLC here is low, and the highest oxygen here in the ECMO group. The mood disorders were prevalent, and the PTS group seemed to be rising at 3 years. There was very high, there was rising primary care, specialty care, and people trying to get back to work, and then few having sustained work status at 3 years. So what are the strengths of this study? I hope I've convinced you that it's a very diverse, it's a multi-center, very highly granular data set. I've only had a chance to show you just a very tiny amount of this, including ICU management, multidimensional outcomes, and a large ECMO sample of 113 patients out to 3 years. We had good follow-up with high internal validity, and I hope I've persuaded you that these patients, based on the highest level of life-sustaining treatment, are on very distinct trajectories. And this informs trial design. It informs the need to stratify. It informs the potential bias that could be introduced in platform trials in very, very sick, complex, long-stay patients. It confirms symptoms are associated with measured outcomes in critically ill patients. And it may help to inform goals of care discussion in terms of mortality and morbidity. We do have limitations. We do not have a control group, but we do have important internal comparisons across the highest level of life-sustaining treatment. Our enrollment is mostly in urban and academic centers. We do not report or adjust for coronavirus variants. We have all this data, but the power is low, or vaccination status, I'm sorry. I hope these outcomes are informative for very, very sick people, but they're not generalized to all COVID survivors. In the interest of time, I just might skip over this. I was just going to say, basically, there's an emerging literature about how COVID may really be contributing more pulmonary and cognitive dysfunction. And I can talk about that at the end if you want, if there's time. And I think we can talk about this too. How much of this is really due to COVID? Well, I think a lot, but we are talking about severely ill ARDS and prolonged vented patients and de-adoption of best practice. So it's a bit tricky because we're trying to understand a novel viral illness when it was challenging to observe usual standards of care. So I'm just going to finish with this, some final thoughts. I've already really stated here that based on highest level of treatment, patients are on very distinct trajectories. They have distinct mortality. They have distinct disability outcomes. And I think these data really could be very helpful to inform patient-centered discussions about goals of care and end of life. And I do think we need to stratify for our CTs that are recruiting these complex patients. I think to answer one of the questions for the new ARDS guidelines, yes, include the high flow patients, but they're distinctly different patients and they need to be stratified. But I might add now that I think we've shown that the vented people might need to be as well as the ECMO people. That the 28-day mortality was not representative of ICU or one-year mortality. And as I already stated, this has, I think, important implications for platform trials. We de-adopted best practice. That was, I think, something we need to be mindful of in the future, and we need families back at the bedside. The post-COVID symptoms mapped to measured outcomes, and we were able to identify phenotypes. And we've really created a population of high healthcare users. One thing I would highlight is that the CANCOV post-ICU follow-up clinic was the only access to medical care for most of the patients in our study. We weren't just doing a research study, we were looking after everybody. That became very apparent early on. COVID was a novel viral sepsis phenomenon, but let's learn from it. It was a traumatic episode for all sorts of patients, families, kids, us, but there's so much to learn here. So hopefully we can really continue to study it and learn from it. I'm going to end there. And thanks very much for your kind attention.
Mark, thanks very much. That was outstanding. There's already numerous questions coming up. So I'm just going to ask a couple that came up right at the beginning of the end of your talk there in the chat. Then we'll flip back to the people who have their hands up. Let me just go back. To what extent did de-adoption of best practice, of best ICU practices mediate the risk of adverse outcomes of critically ill COVID-19 patients?
Yeah. Sorry about the coughing. I'm just sort of getting
That's okay. And
bad viral illness myself and my family. Well, I think this is the challenge. And I will say that we did this in SARS too. We kept everybody away. We sedated and paralyzed everybody. And it's not without thought. I mean, I don't want to be critical of this. I did this too. I was working through all of this. I mean, there were early on before vaccination. I mean, I think people wanted to make sure the patient was safe. The patient, we weren't, subjecting the patient to injurious lung strategies. People were trying to minimize contact in the room. I think there's no question that there is some degree of exacerbation of the usual ICU-acquired weakness and unfortunately the brain injury because people were in deep coma a lot. And I think that was difficult. I don't have a simple solution for how we mitigate that, but I'll tell you one thing. I really would want to say here, we must never keep the families away from the bedside again. They're so traumatized by this, and I really don't think the risk it didn't favor what happened to people. Families in distress need to be with the people they care about, bottom line. And keeping everyone away was so traumatizing for everybody involved. And that's a huge learning point we must not repeat. Lots of iatrogenesis, though, to answer the question, unfortunately.
Mark, perhaps just stop sharing your slides because they're showing up still so we can see
Oh, sorry
everybody.
about that.
Yeah, no, that's the point.
Is
And
that
then
okay
one
now?
more. Yeah, that's good.
Are
One
they
more
off now,
question.
Jane? Yeah, thanks.
No,
Sorry
they're
about
off. Yeah.
Yeah,
Yes.
sorry
I'm going to
about
ask One more question from the chat, then we'll pop over to the hand. Do you need to get it? Do you want to grab a glass of water, Mark, and
No, it's
come back?
okay. It's just chronic. Like I don't know what to do now. It's just sort of
Need to
ongoing.
see a respirologist.
That'd be a good idea. I see a few on the call.
Any data regarding which patients presented with most severe symptoms required ECMO ventilation?
Any data on which patients, like within, well, the ECMO patients had the most symptoms for sure. Is that what the question is? That
I think
or
it's which cohorts of people, or can you
oh oh
break down?
oh
Yeah.
oh yeah, okay. I can't really I can't really answer that question very well. We recruited the most people during the Delta wave, like because that would make sense to you. They were the sickest, and that's when we recruited a lot of people to this study. They were the sickest, and they contributed probably the greatest signal to symptoms. As I said, we could stratify by the the different waves of COVID, but that's the wave that we recruited the most to. So it sort of confounds the comparison a little bit, just to be very honest about that. But I think it's very, very clear that the higher the severity of illness and life-sustaining treatment, the more people were, had higher mortality and more symptoms and physical sequelae, for sure, and psychological sequelae too.
Okay, Bruce.
Yeah, thank you, Margaret. Amazing work. Also, thank you to you and your research colleagues, your ICU colleagues for all your work over the pandemic. I hope that sounded sincere. It was meant to be.
Oh, of course. Thank you.
Two kind of related questions. So, you paint a really bleak picture. We all are left with the impression that you're in an ICU with a condition like COVID, that you're never living a normal life again. So, I guess the first question is, what can you communicate as like the proportion who are resilient to morbidities? And then the second question is, in your research, is there a possible selection bias, like those who are participating in long-term follow-up, or those who
Mhm.
are doing the worst, those who are living well and want to put this behind them are not selecting to be part of your study? So first is, what proportion are resilient to morbidities, and second is, how much selection bias in the
Yeah.
research?
Yeah, well, I think, these are important comments. I think that there's maybe I can say this, Bruce, that clearly not everyone on ECLS died, but there was a lot of morbidity. But I would say that we definitely have people in the cohort who were younger. They were like in their 40s. They were entirely healthy athletes. I mean, we have people like that. What happened to people like that? They would tell you that they got almost completely better. But what was the almost about? The athletes tell me they can't. They've lost their physical endurance. They've lost their ability to do more extreme physical exercise. And by the way, that's what our ARDS patients told me years ago. That they've had a bit skimmed off the top. So they perceive that. We haven't done exercise tests on all these people, but I bet if we did, we would find that. What else like, there was a patient even on a recover cohort. He was a marathoner and he was like 35. He went back to doing marathon running, but he could never regain uh, his stats again. Like he could never regain his elite status again. It was just that was the cost of being sick. The other thing that the younger patients who've recovered say, that they are aware of some minor cognitive dysfunction. It's not necessarily interfering with their ability to do their job, although for some it is, but they're aware of it. They're aware that they have some degree of memory impairment, their executive dysfunction, although it's not preventing them from going back to work. They're aware of it. Their job is harder for them than it used to be. Those are the sorts of morbidities that people have who say they are, really doing very, very well. In terms of selection bias, Well, I showed you our follow-up numbers. We've really tried to not lose anybody, and the team has done an exceptional job of that. Um, it's are there some people, well, it sort of works both ways, right? I mean, there's some people who are really doing well, but were incredibly sick and just want to keep telling us how well they're doing. I mean, it's sort of there are a number of different, what can I say, reactions to having been this sick. Not necessarily wanting to get away from us, but actually wanting to stay close to us. I mean, us, the clinic people, because we were with them during this recovery. Like it becomes a very bonding experience. That's why the follow-up is good. People want to keep in touch with you. Could there be a little bit of bias? Yes. Do I think it probably explains the results? No, I don't. I think the results are quite robust. And when we start to look at ICES and larger data sets, that will also help validate that there wasn't a selection bias, but in fact, this is what happened.
Thanks.
Yeah, John?
Again, congratulations, Margaret, for a fabulous body of work over decades. With respect to your comment regarding the uniqueness of COVID,
Yeah.
one of the things that I see in my clinic are referrals for postural orthostatic tachycardia syndrome
Oh, yeah.
or primary autonomic failure, and I've never seen those post ARDS or sepsis. Do you think that is something unique to COVID? Do you think this is something that is a function of greater recognition? Generally, these are individuals who are not in an ICU, but this seems to be part of their long COVID presentation. You didn't touch upon those two
No,
syndromes, but
I
I
didn't,
think family
John.
physicians seem to be aware of them and send them along to me. So is this part of your experience or
Yeah.
Andrew's experience?
Well, it's interesting, John. I think what we see in our clinic, and Angela may want to talk about that, in sort of the problems after the non-ICU patients, but in the non-ICU patients, but in the ICU patients, we haven't really seen so much of that, to be honest with you, in clinic. That's why I really didn't mention it. And it's possible, John, that, a lot of people died. And it's really possible that some of these, oh yeah, and Sandra's weighing in on this, and maybe she wants to talk about that too. But I think for the ICU patients, maybe even to some of our previous discussion with Bruce, a lot of people didn't survive this, and so we may have a different picture of what the sequelae are because a lot of the people just didn't get through it, at least in our group. But I don't know if, we haven't seen so much of that. The problems that I outlined here are really what people are talking about. A lot of them are sequelae that we see after ARDS and sepsis. But just didn't want to finish too late. But I would say with greater theme of cognitive dysfunction and a greater theme of pulmonary dysfunction, they have worse pulmonary outcomes for sure. And again, it's not clear whether that's related to the heavy steroid use, the prolonged vent exposure with recurrent ventilator-associated pneumonias and sepsis. But I don't know if Angela or Sandra was in the chat. They want to speak to that, but that was not a prevalent issue, John, in the ICU people.
I can comment just briefly on this. We do see a lot, and I have to say that the whole spectrum of dysautonomia is quite prevalent. Some are cardiac, but some are respiratory. They have dysfunctional breathing. We see dysautonomia in the GI system as well, and so this is a fairly neurotropic virus, I would say. And there's ongoing theory about sort of why that's the case. But in general, it's immune dysregulation, and for the long-term stuff. There's lots more data on the non-ICU side, and happy to sort of show and discuss at a later date. Yeah.
Thanks. We're running out of time here. Matthew Binney's had his hand up for quite some time. So Matthew, please go ahead.
Thanks. Congratulations, Margaret, to you and your team for really some remarkable work. I wanted to ask about correlations that between the factors people had at presentation and ultimate good outcomes, and what conclusions you've drawn about who should be placed on ECMO in these situations.
Yeah, I think, Matthew, I mean, it's a longer discussion, but I will say that when we looked at, a priori determinants of ICU mortality, what comes out are age, which we expect, burden of comorbid illness, and the early resolution of multi-organ dysfunction within the first week of ICU stay. So I don't think our data set answers who to put on ECLS. I think it informs more how long people should stay on ECLS. And even that point, I'm not completely sure we have a great answer about. But I think, I will say at least at 28 days, which increasingly, right, in our unit, that's not so uncommon. It's clear that with each additional week, there's a high mortality, and with each additional week, there's a high morbidity. And I think that information can be helpful to have conversations about consent to ongoing treatment, understanding that mortality and morbidity continue to rise. And maybe that's acceptable to lots of folks, but at least to be informed that the road back is enormously protracted, complicated, and painful. And I think lots of people seem to want to sign up for that, but I think that's where these data may be more informative, is just in terms of frank discussions and informed consent about what's happening. And but I would say if people aren't really, you're seeing organ dysfunction and it's only sort of getting more complex over the weeks. We've been pretty disciplined. I only showed you data we plan to look at, so we have a lot of more papers to write still. But I think when patients become more complex rather than less in the first 1 to 2 weeks, I think that's a big problem. And we see that in this data set, and it's going to be much harder for you to recover and to have a good outcome. Yeah, Alan's writing this. Yeah, that's right. And you need to get better quickly in the unit, or you just get trapped by the iatrogenesis. That's really a major issue. And when you're sick like this, it's a real challenge to get better again. Absolutely, Alan. Yeah.
Well, we're at the end of the hour. Marg, thank you so much. As you can see, there's a massive amount of interest. So perhaps I can, if you're available and people still want to ask you questions,
Sure.
are you willing to stick around? We'll just
Oh,
leave
you mean
it
like
open
right
then.
now? Oh,
Yeah, like right now. If there
Oh,
are people who want to
okay.
ask you a question
All
rather
right,
than
sure.
having to follow up. I will stay on too to help. I do have another meeting I have to head off to in a few minutes, but it can,
Yeah,
because
sure, for
Ramona, this can just stay running. Is Ramona
5 or
there?
10 minutes. Yeah, sure, no
Yeah,
problem.
you're okay, Marg, with that?
Yeah,
Can
of
I,
course, no
okay,
problem.
sure. So those of you who have to leave, thank you so much for joining. Please do not forget to fill out the evaluation for Marg and for the citywide medical ground rounds. Those of you who would like to stick around, we've captured Marg here for another 10 minutes. Great. Jillian?
Congratulations again. Fantastic. Margaret, what I meant from my question earlier about who came in sickest
Oh,
is,
that was her, yeah.
were there risk factors? So was it, you mentioned strain and the wave, but were there particular groups? I know we heard a lot about particular groups, but
Yeah.
social determinants of health, specific comorbidities, anything that really was sort of a predictor of how sick people got with at least those who got to the ICU.
Yeah, for sure, Jillian. I will tell you that we will be able to answer that question, but we were really disciplined about all the modeling. And we only modeled what I've kind of showed you, to be honest with you. And the data set is so huge that we tried to be, and also I just want to be able to say in the papers that honestly, that we weren't looking around at the data, that we did pre-planned analyses. We will be able to answer all of that with the data set, but we wanted first to, look at some of these other kind of bigger observations, and then drill down a little bit more. I have no doubt that, like as I just mentioned about the to Matthew's question, or in answer to Matthew's question, I mean, age is always important. I mean, it's just people don't like to say this, but of course, it's the one marker of physiologic organ reserve is age. On average, people can be different. I think when we see the signal from any comorbid illness, when we start to drill down to specific comorbidities, I suspect we will see some signal there. Obesity and morbid obesity, because they're really chronic inflammatory states, really created vulnerability for this population. And we see it now in terms of the influenza and RSV that's in the unit, like I was just on call last week. There's these chronic, inflammatory states really create vulnerabilities. And the people who presented in extremis just didn't do well. And how do we define extremists? Well, we'll create a model where we can really model people who, had severe ARDS and were on needed pressor support, that they came to us and they were catastrophically ill. It was very, very hard to rescue those people. I think we felt and I agree with this, we needed to try and put these people at least on a trial of ECLS, because so many of them were so young and they came from their house, for heaven's sakes. I mean, they came, like I showed you, these weren't chronically sick people. Right. They were really living independently. And so I think people really wanted to be very heroic about what we were doing. And I mean, I would agree with that. But I think these are some of the things, I'm just speaking kind of from clinical observations now, but I'm sure our modeling will show that. And, and there were different distributions of death. Some people early on who they were hypoxemic. We couldn't oxygenate them even on ECMO. They had profound hemodynamic collapse. We couldn't support them with high dose pressors. It was like that. But, so I think we'll be able to answer that, but I just can't honestly, I'm just giving you sort of my impressions. Yep. But we will answer that eventually for sure when we drill down a bit more in other papers. Yeah.
Thank you.
Margaret, I'm obligated to go to another meeting that's really important. However, there are many people online. To everybody online, Dr. Herridge has graciously offered extra time. Please be cognizant of that. Marg, please feel free to pull out when you need to. Yeah, but I'm going to let you go ahead if that's okay.
Yeah, of course, for sure. I'm happy to go, until 1:15 or something like that. Yeah, go ahead.
Okay, thanks again.
Bye. Yeah, okay, Jane. Yeah, sure, Jackie.
Hey, Margaret. Great round and understanding. And as you spoke about it, I was personally reflecting on my sister-in-law's daughter, so my niece through marriage, her boyfriend, who was in his 20s and completely healthy, died of COVID in Vancouver. He went from normal to dying in like hours. So what you say about the tragedy of some young person just being completely devastated by this, but you've got the cohort of people who survived. So my question is around these were early admissions, right? So is it presumed, you didn't talk a lot about vaccination, but these were people in the unvaccinated time when this was happening? And then that's the first question. And then going forward, then COVID hasn't gone away, but at some point, seriously, people are not going to be protected anymore because they're all going to stop getting vaccinated. That's going to happen. And what's the risk going forward that we might have a resurgence of people who might be susceptible to this form of illness in any sense. But just to the question of, are these mostly people who are not vaccinated?
Yeah, I mean, I didn't present the vaccination data. We're still actually looking at that. Like, a lot of these things we're trying to evaluate now from the data set because it's so huge. What I can tell you about, well, obviously, in the early waves, people weren't vaccinated. So that's an issue. I think maybe the most stark um, observation, just now, kind of me informally now, was when we had the later waves where there was a real anti-vaxxer movement. And what we definitely saw people in the unit critically ill, and I would say almost all of them had declined vaccination. And I mean, that's just sort of a kind of an opinion at this point, probably more of an opinion or an impression-based statement. But for all of us in the unit, it was so striking that and we lost a lot. A lot of people died. And it was just kind of horrifying because they had clearly decided not to be vaccinated. And it wasn't 100% that all the people hadn't been vaccinated, but it was a very, very robust theme and a very strong impression that these patients, unfortunately, had a much more severe level of illness because they had not been vaccinated. So I can say that the later waves, that was very much the case. We do have the vaccination data. We can parse our cohort into the different waves. But as I said, I'm trying to be kind of honest about, we don't really have a lot of power because when you take our data set and you parse it into the different waves, the numbers drop and it gets very hard to understand, associations because there's not a lot of statistical power. But I am concerned about that. It'll be interesting to see if people decide to get RSV vaccination after this flu season. We've got lots of RSV in the unit at the general, lots of influenza in the general right now, young people, 30-year-olds who I don't know what their risk factor was on ECLS. I mean, that is a thing. And how we prevent or understand the complex biology of that, I'm not certain. Steroids kill people. I mean, the steroid patients on chronic steroids, they show up a lot, and it's always heartbreaking. Lung transplant patients, kidney transplant patients, people on chronic steroids for connective tissue, collagen vascular things. I mean, there's such a vulnerable group to these horrible viral illnesses. And obesity is another very, very common risk factor. BMI's over 30. I mean, it's very, this is another important risk group for sure.
It's a good reminder for all of us metabolic doctors to remind people to get vaccinated. Almost everybody in my class. I'm just kidding.
But it's true, Jackie. It's true. Actually, it's a really, really vulnerable group, and I don't think everyone necessarily realizes what obesity does to someone's physiology.
Can I ask Angela a question?
Yeah, ask Angela. She's here.
I see her. The post-COVID, long COVID syndrome, in rheumatology, we've lived through the emergence of fibromyalgia, chronic fatigue, and these, how it sounds like the long COVID is quite dissimilar from chronic fatigue some ways, but do you
There's
have a
overlap.
sense? Sorry, there is overlap.
There's definitely overlap between the two, and as I mentioned, there's a lot of dysautonomia in this population, and actually, there's emerging data that comes out that shows that it causes hypertension, it actually increases the risk of diabetes, and a lot of metabolic issues, fatty liver, and other things as well. And so it is multi-system. And so like every system, there's literature. It's like, every day there's a couple of papers on various parts, like, how there's more p-tau protein in the brain in terms of the cognitive dysfunction, which usually is observed with Alzheimer's disease. Anyway, so there's lots going on in many different areas. And in the rheumatological area, it revs up autoantibodies. And so I
Yeah.
get a lot of people that comes to see me because they have abnormal positive antibodies that the family physician has ordered.
Yeah.
But they don't have, they don't have actual diagnoses per se. There's a couple, like we've diagnosed a rheumatoid arthritis patient, we've diagnosed a scleroderma patient, but outside of that, it's a lot of revving up autoantibodies because it's a foreign sort of like people haven't seen the virus before, and so your immune system just sort of explodes and revs up sort of autoimmunity.
But that's true of really all infections and viruses. I guess
Yeah.
there's also going to be a lot of surveillance bias as we follow the post-COVID
Oh,
folks
yeah.
because they're going to be watched closer and
Yeah.
differently.
Yes.
So it'll be
Yeah.
interesting to see. Thank you.
Yeah. Thank you.
Thank you. Well, maybe, yeah, that's great. Yeah, Abdu. Okay. Well, I don't know. Is it okay to get sorry, I'm going to try to nurse my cough a little bit
I think
here.
you can get off the phone.
Yeah. You did a
Thank
great
you
job,
all.
Mark.
Thanks
Yeah.
for all the
Fabulous job.